I will try to share the screen and show you the planning of today. So this is the plan. This is, I think everybody is hearing me. Bernardo, is it? I am loud and clear.
Okay, very well.
Can you see me also?
Everything is perfect.
Okay, so the Indo-European Course on Revascularization was the initial meeting where we had Dr. P.C. Rath as one of the course directors, and we had how can we see others? We had started in 2008, and we have done courses in London, Paris, Rome, Amsterdam with Dr. P.K. Ashokan, Dr. P.C. Rath, myself, Dr. Alan Cribier, Dr. Elil Alshanjaf, Dr. Bernardo Cortez, who came to attend our meetings in various places. He did live transmissions, and Dr. Professor Romeo we did in Tor Vergata, Rome. So I am not able to see everybody, but I will just try to take help of my IT. This is the first webinar we are doing. So I want to see everybody also. So this is the planning. I'll start. I'm taking help of my. See what you do. So Bernardo, yes. No, but I cannot see the faces. Okay. I think now we are starting, so I will do my presentation first, followed by the Dr. Romeo and Dr. Romeo and you. Yes, doctor. Okay, so Professor Romeo, good morning for good afternoon. Dr. Romeo, can you hear me? Yes. Okay, so I have unmuted everybody except you can say hello to Dr. P.C. Rath. P.C. Rath.
Hello, Dr. Romeo. How are you? And how is your now? Good.
So Dr. P.C. Rath is senior cardiologist in Apollo Hospital, Hyderabad. I am calling from Delhi. Dr. Professor Romeo is calling from Rome. Dr. Bernardo Cortez is a good old friend from Milan. So we are four will be speaking, the rest will be listening, and we can take the questions later on. So I will ask my IT person to stay here so that he can keep admitting everybody, admit all candidates. Whosoever is joining, so we have more than 55 participants as of now, 60 participants as of now, and hope that it will keep on increasing as the course go on. So the plan of presentation will be like this, that everybody is muted as of now. I will try to unmute the people who are there. I will say hello to Dr. Anu Malik. Can you hear me? Mr. Malik, Anu, he's a Bollywood singer and music director and celebrity. He is very nice to join us. Can you hear me, Mr. Anu Malik?
Yes, I can hear you. Hello.
Hello everybody, let me introduce to our Italian friends. He's one of the very celebrity guy who has been doing the Bollywood music, Indian music composer. He has done a lot of such music, and he's our good friend. So he's agreed to, as a social person, he will be giving some talk in between after you speak or something. So I think it was going to be very interesting webinar. And you can see this is our live, and I'm requesting my IT people to stay with us. So I start my presentation now. The topic is COVID-19. I hope that everybody is clearly listening to me. Bernardo, can you hear me very well? And Dr. P.C. Rath, can you hear me? Where is Dr. Ashokan? I cannot see Ashokan. I think I will start. I will start now our presentation. So let me start my presentation, and this is the presentation which I am going to do. Share screen हुआ? करो.
Hello, doctor.
Yes, I am going to start my presentation now.
Dr. Gupta,
Yes.
good evening.
Good evening. I have already introduced you to everybody. You are the from Bombay calling and helping us to do this live, and so I am going to start my presentation today. So I will take about 15 or 10 minutes to introduce COVID-19, which is a big problem and havoc for the whole world, and this is something like World War III. And we are very much facing all the problems, and so this started in China and Wuhan, everybody knows about it, and globally it is now affecting more than 200 countries, 220 or 210 countries, and as of now 12 million people are infected and more than 1.2 lakhs people are dead. Indian figures are not so bad because we have started lockdown with our Prime Minister Narendra Modi ji starting the lockdown on March 22. And yesterday it has been increased further to May 3, 3rd May. So I am very positive that this thing we are able to do. But still, 11,000 people are infected in India, and we have more than around 400 deaths. So let me introduce further to our topic, which is COVID-19. It is like a normal viral disease. It started in China, in Wuhan in December. People are blaming that it was possibly in November. It is known as COVID. It is a SARS-2 virus. And it is one of the, it turned out to be, initially it was a common flu, but turned out to be really very dangerous virus. And it can show you that everybody here, you can see that SARS-CoV-2 entry and replication, antigen presentation, cellular immunity and humoral immunity. So in this webinar, there are doctors and there are few non-medical persons also. So I will be talking a little more medical as well as non-medical. So this is the diagram, flow diagram, which shows the entry into this, and this is the immune drainage which happens into the body. So coming on to the topic again, coronavirus entry and replication. Coronavirus S protein has been reported as significant determinant of virus entry to the host cells. This is the S protein which is actually dangerous. The envelope spike glycoprotein binds to this AC2 receptor for SARS-CoV-2 and COVID-2. The entry of SARS-CoV into cells was initially identified to be accomplished by direct membrane fusion between the virus and plasma membrane. And the entry and replication takes place like this. After the virus enters the cell, the viral RNA genome is released into the cytoplasm and is translated into two polyproteins and structural protein, after which the viral genome begins to replicate. The newly formed envelope glycoproteins are inserted into the membrane of the endoplasmic reticulum. It's more of a theoretical thing for doctors to understand, or Golgi body. And the nucleoplastid is formed by the combination of genomic RNA and nucleoplasmid protein. Then the viral particles germinate into endoplasmic reticulum, Golgi body. It's little too much to understand for the public forum. But we have said that this virus actually is dangerous. Currently, we don't have any report about antigen presentation of SARS-CoV-2, and we can only get some information from previous researches on SARS-CoV-1 and MERS, which came in 2008. Next slide we go, and then we will humoral cellular immunity. I am going to present this thing because this is very important for the plasma therapy, because the plasma therapy is one of the important tools now to treat the patients who are COVID infected. So I have been told that the antigen presentation, come back here. Okay, the antigen presentation subsequently stimulates the body humoral and cellular immunity, which are mediated by virus-specific B and T cells. Comparing to humoral responses, there are two more researches on the cellular immunity of coronavirus. The latest report shows the number of CD4 and CD8 T cells in the peripheral blood of SARS-CoV-2 infected patients significantly reduced. And that is why, whereas the status is the excessive activation. So I'm little skipping all those complicated slides because we have more speakers now. So I'm leaving this slide as of now, but I'm going to cytokine storm. This is very important. The report in Lancet shows that ARDS is the main death cause of COVID-19. One of the main mechanisms for ARDS, acute respiratory distress syndrome, is the cytokine storm, the deadly uncontrolled systemic inflammation response resulting from the release of large amounts of pro-inflammatory cytokines. The cytokine storm will trigger a violent attack by the immune system to the body, causing acute respiratory distress syndrome and multi-organ failure, and finally lead to death in severe cases of SARS-CoV. We all know the mortality of this is around 15%. In Italy it was a little more. It is by the age-wise, the mortality that young people who are less than 40 and 50, they have mortality about 2 to 3%, while when the age increases or when you have comorbid conditions like diabetes, hypertension, coronary artery disease or cancer, where the immunology is disturbed, at that time you have more number of morbidity, more mortality. So clinical diagnosis, I'm trying to wrap up the whole COVID slowly and fast as well. Clinical diagnosis of COVID-19 is mainly based on epidemiological history, that is history of travel, clinical manifestations, nucleic acid detection, CT chest scan, immunological detection of ELISA and test of IgM antibodies and blood culture. So this is nucleic acid. Clinical symptoms and signs of patients infected with SARS-CoV-2 are highly atypical, including respiratory symptoms, cough, fever, dyspnea, and viral pneumonia. Nucleic acid, this is very important. We all know the test RT-qPCR test, real-time quantitative polymerase chain reaction. And this is a test which is being done as a detective test for this. The authoritative identification method for SARS-CoV-2 is virus blood culture. But we are not doing that. We are doing from the throat, the nasal, the sputum and other things. However, the application of high throughout sequencing technology in clinical diagnosis is limited because of equipment and depending upon high cost. So RT-qPCR is the most common, effective and straightforward method for the pathogenic diagnosis and from the respiratory secretions. We are using respiratory secretion as the main way to diagnose. What is the radiological diagnosis in COVID-2? RT-qPCR is specific test for diagnosis of COVID-19. However, its false negative rate cannot be ignored. It cannot be ignored because of the severe consequences of misdiagnosis. That means there is a false negative test also of the RT-qPCR. Hence, CT scan can be considered as necessary auxiliary diagnostic method because it is more sensitive. This is a very important point. CT scan for individuals with a high clinical suspicion of SARS-CoV-2 infection with negative RT-qPCR screening, a combination of repeated RT-qPCR test and chest CT scan may be helpful. Especially the high resolution CT scan of the chest is essential for the early diagnosis and evaluation of disease severity of patient with SARS-CoV-2. This is the typical CT image, shows bilateral pulmonary parenchyma, ground glass, consolidation, pulmonary apostasis, sometimes with a rounded morphology and peripheral lung distribution. So how the medicines work? This is an important diagram which I want to show you. This is how the virus comes, attacks the cells. We all know hydroxychloroquine is considered to be one of the important drugs at the moment. This is helping at the level of membrane fusion and endocytosis. While the antiviral medicines like lopinavir and duranavir, ribavirin, and these are acting at the level of proteolysis at the protein level, at the cellular structure. So we have 2-3 mechanisms where these drugs are working. Of course, the other antibiotics and the supportive treatment of oxygen, but this is a definite way to treat and help the patients. What about hydroxychloroquine? This is a very important medicine coming out, but I'm trying to do a randomized trial to evaluate the efficacy. The 2 patients were confirmed. So I'm going to just give you a summary rather than reading out. There was Chinese study, Wuhan study, where they did not show much difference. But then there was a French study from Marseille, France, where they confirmed that this is going to be effective in reducing the severity. This is not reducing the onset of symptoms. It is reducing the severity. The mild symptom will not become to severity. So this was a study which showed that of the total study population, the more number of patients in execute treatment group compared with control group showed improvement of pneumonia and CT chest. This was a 54% versus 80%. So this was a significant reduction in improvement in pneumonia when you are giving hydroxychloroquine. So this is the conclusion. So I would like to, this is conclusion of hydroxychloroquine. Despite the small number of cases, the potential of SCQ in the treatment of COVID-19 has been partially confirmed. Considering that there is no better option at present, it is a promising practice to apply SCQ to COVID-19 under reasonable management. However, large-scale clinical and basic trials are required. So one last thing which I want to speak about the hydroxychloroquine is that Indian Council of Medical Research has recently given the guidelines as a preventive modality for healthcare workers. 400 milligram of SCQ twice a day for 1 day and then once a week for 7 weeks. This is hydroxychloroquine suggestion. But of course, FDA has different system. But coming on to ivermectin, which is a new medicine which has been tested in vitro, and there is no in vivo study, but it is coming up soon, and there will be trials for this. The ivermectin is a FDA-approved anti-parasite drug, which has shown within 48 hours it kills the COVID-2 virus in vitro. But we don't have, as of now, as my knowledge is concerned, it does not show, we don't have any in vivo trial as of now. I will quickly go into the antibodies plasma treatment, but I think I have to skip all these slides because of time, paucity, and we have more speakers. So, Italian doctor's perspective will be told by Dr. Franco Romeo. Vaccine and offering I will give in the last minute if I have time. This is an important point I want to tell you. The contact tracing. You see that the way to control this pandemic or epidemic is to do social distancing, to reduce the contact. So there is one app which has come up from our Ministry of Health, which has to be downloaded on the mobile Android, and it will tell you whether you have contacted anybody during last 7 days or 6 days. If you have contacted anybody, if anybody has symptoms, they will say yes, and that all the contacts of this person will be given by this app. So this is important. And coming back to my slides, European studies are there. Plasma antibody therapy is coming up soon, and the plasma is taken from the patients who have suffered, who have got the antibodies, and this is infused into patient of the COVID-19, and this has shown a promising results in India as well as in Europe. Ventilator treatment is not final. This supports only those patients who are there. I think we have to mute everybody. Sorry. I'm trying, just hold on for a second. I'm taking help of my guys to mute everybody so that we can because mute all. Okay. So we are muting everybody and coming back to the slides. So is it slides are okay? Okay. I'm coming back. So healthcare workers are very prone for this. This is important. More than 2,000 healthcare workers have been affected all over the world. In India, more than 200 have been quarantined. There are many deaths. So I request all the healthcare workers, which include the doctors, nurses, the hospital staff, the delivery boys, the chemists inside the hospitals, to at least take hydroxychloroquine. At least if they are affected, they should not be affected to that extent. So this is my last slide it was showing, and I think I will finish off my sharing now, and I will go back to Dr. Bernardo. I'm unmuting you. I will request, I'm unmuting two people at the moment, Dr. Romeo and Dr. Bernardo. Dr. P.C. Rath wants to come in at this point of time. So after P.C. Rath, he will tell about the Indian perspective of heart failure and Indian perspective of heart failure and COVID-2. After Dr. P.C. Rath, we'll take Dr. Romeo or Bernardo, any of them, and then we'll take a question answers and few people, and Mr. Anu Malik, if he's available still on the phone. I think he's available, yes. So Dr. P.C. Rath, where are you?
Good afternoon, Vivek. Can you hear me?
Yeah, I can hear you very well. You can go ahead with your presentation. We are loud and clear. Everybody's hearing.
Presentation?
Yes.
Okay, thank you very much all participants. I must thank Dr. Vivek Gupta, a good friend of mine, who has taken the trouble of organizing all this webinar, and he has contacted Dr. Bernardo and Romeo from Italy, who have agreed to participate in spite of the emergency that they are facing here. I have to speak on COVID-19 and heart failure. And as you know that COVID-19 patients with underlying cardiovascular disease I mean, it is discovery. Underlying mechanism of cardiovascular noise that all these patients of COVID-19 patients, 30% are hypertensive patients, diabetes mellitus patients, 12%. The mechanism already Dr. Vivek Gupta has told you, but the main mechanism is angiotensin inhibitor receptor. This virus gets attached to the protein of this angiotensin inhibitor and then damages the valve. And that because of damaged valve, the virus enters into the cell. So that is why that's the one of the mechanism of this. These ACE2 receptors are they are in all the vascular gate, they are available in the endothelium, iliac cells, in the testes, long kidney, gastrointestinal tract, they are everywhere. So
The Bluetooth device is ready
the
to pair.
virus goes in, and after virus goes in,
The Bluetooth device is ready to pair.
damage the whole cell. And this
Mode.
there is a postulation that in patients who are taking angiotensin 2 inhibitors, that drugs, ACE inhibitor, ARB, its ACE1 receptors are increased, and the chances.
Dr. Rath, can you speak a little louder? We are hearing you well, but little louder will be better.
Can you hear me now?
Yeah, I can hear you, but a little louder will be better. Yes.
Okay, fine. The mechanism is this virus directly affects the heart, and through this mechanism, receptor, they affect the heart directly, or when in the end stage of disease, when there is a lot of inflammatory cytokines, the heart is also affected. Patients who are already having pre-existing cardiovascular disease, this damage is much more. Not only directly, but also because they develop pulmonary infection, pneumonia, and hypoxia, that also precipitates the heart failure. And many of these patients develop arrhythmia and heart failure precipitate further. Myocarditis, acute myocardial infarction, and exacerbation of the heart failure are also the symptoms of this COVID-19 infection. And these are associated with significant burden of cardiovascular morbidity and complications. So the mechanism of this injury is fourfold. First is, as I told you, ACE2 modified damage to the cell, hypoxia-induced injury to the myocardial cell. Cardiac microvascular damage also occurs. Microvascular damage causes the damage to the muscle, myocardial muscle. Systemic inflammatory response because of cytokine storm, that also affects the heart. In recently, on 10th of April, there was a report that was sent to European Heart Journal, which is not a published, came from Italy. They found that in the biopsy of a patient, cardiac biopsy of a patient who just died of cardiac shock, and they found inside the heart muscle this COVID-19 COVID-19 virus strains. So probably it also affects the heart muscle directly. There is all the indirect mechanism which I illustrated earlier. So all the data that we have mostly from China, because China first and all these data are from China. This is a study meta-analysis of 6 studies from China published in Clinical Research and Cardiology Journal, and involves 1,527 patients, and it showed that 17% of the patients affected with COVID-19 are hypertension. Cardiocerebral vascular disease was in 16.4 patients. Diabetes 9.7%. But you see the twofold higher and the incidence of cardiovascular disease.
I can't breathe.
Threefold higher in ICU admitted patients. Those patients were at ICU, hypertension and diabetes, more with hypertension, more with diabetes, and threefold more with patients with cardiovascular diseases. At least 8% patients had acute cardiac injury. Their troponin I was elevated. The incidence of acute cardiac injury was 13-fold higher in patients with ICU. So all ICU patients have with more diabetic, more hypertensive, more cardiovascular disease, and 13-fold high increases in cardiac injury. 13-fold patients had troponin I was elevated. There was another study which came from one when the study started. It was from one hospital, one city hospital. There is 187 patients retrospectively studied, and what they found was a very interesting thing. They found that patients with cardiovascular disease, when the troponin I was elevated, the mortality rate was around 60%. And patients who had cardiovascular disease, but troponin was not elevated, mortality was 40%. But patients with cardiovascular disease with no troponin was not elevated at all, there the chances of survival was much better. So troponin I was an independent risk factor for survival, and most were the patients who had having cardiovascular disease with troponin I elevation. There the mortality rate was very high, around 60%.
please.
Then there is a concern about because the ice is brought, this virus acts to the angiotensin, this renin and SGH inhibitors. Yes, so there is concern whether it is safe to use SGH inhibitors or ARB. This concern was there, and initially there was a lot of frustration that better not to use, but subsequently that the HCCS guideline was very clear that this is recommended that you can continue this RAS and terminate for those patients who are currently prescribed. First indication, those who are already on, you should continue, but those who are, is probably more logical not to start, but there's no harm in continuing those medicines. This is the disease states and how potential therapy. The slide shows very clearly initial stage of the disease. Viral response phase, where the patient presents with cough, mild cough, fever, just and that time lymphocytes are elevated, increased procalcitonin and all that. And then subsequently they go into pulmonary phase, where they have shortness of breath, hypoxia, and some abnormal chest and imaging. If you do the imaging, you find pulmonary patches. And stage 3, the last stage, where there is a hyperinflammation phase, where patient develop ARDS and patient goes into shock, cardiac failure, many arrhythmias. That time elevated inflammatory markers are also elevated, CPK, LDH, and D-dimer, and troponin I. The planned treatment already Dr. Vivek has highlighted the role of chloroquine, antiviral drug, but nothing has showed supportive measures is the only thing, and if the patient becomes hypoxic, you give support the patient with ventilator and some role of steroid in the patient who are in shock, can give steroid in those patients, and this is the role of even plasma from the recovered patients. Plasma is given to some sick patients and they recover. That is a new hope for the very, very sick patients. In conclusion, patients with pre-existing cardiovascular disease have 3-4 higher risk of critical illness requiring ICU care. Raised troponin is an independent risk factor for increased mortality. Mortality rate in cardiovascular disease patients with elevated troponin is at 60%. But at this time, this time of COVID-19 pandemic, most important, these high-risk individuals need to be protected by strict preventive measures. They should not come to hospital for consultations, and they should be encouraged to take teleconsultation or they can talk to their doctors and ask for consultation unless it's absolute necessary. Thank you very much for that.
Thank you, Dr. P.C. Rath. It was a very nice presentation, and I think we can see everybody again If I allow, I will just, Bernardo, I'll just request our friend, Dr. Mr. Anu Malik, just to say a few social words, and then Mr. Malik, you talk again after the finish. So, Mr. Anu Malik, would you like to say something? Just say hello to everybody.
Hello, all the doctors. Can you hear me?
Yes, perfect, loud and clear.
So it is an extreme honor, and thank you, Dr. Gupta, for having me over with such illustrious doctors who are speaking about the COVID 2019 pandemic, which has literally taken so many lives. But congratulations to our Honorable Prime Minister Modi ji, who has, to a point, really succeeded in keeping the death rate down. God bless him. And also to all the doctors all over the world who are putting their lives at risk and taking care of each and every patient, especially the doctors from Italy. I would like to say a special thanks. And I don't know whether you heard much of my music, but I've been hearing so much about this medical talk that has really scared me. So I've gone back to my music.
Mr. Anu Malik is a great friend of ours, and he's one of the celebrity music composer and singer in Bollywood, which is very popular all over the world. I will request him that at the end of the show, just to make it light, I would like to hear 2 sentences later on, just to make everybody light in such a serious modality. Let me introduce Dr. Ashokan now. PK Ashokan is just to say hello. He is one of the important person from the beginning with ICR, and Bernardo knows him very well. And so just say hello, and then I will take your discussion later on. Ashokan, you can say hello.
I think it's very important topic taken right time. I think we'll get a global views, especially from southern part of Europe and other part of India. I think it's very important.
Okay, thank you. So I move on to Bernardo. If you allow me, I can request Dr. Francisco Romeo to start topic, and then you will take up. Is it okay?
Yes, please, Professor Romeo. I will follow you.
Okay, Professor Romeo, let me introduce him first.
So I will be very short, just to share. Thank you, Dr. Gupta. As you know, I work in Tor Vergata University Hospital. We are COVID hospital, one of the smallest, maybe the biggest COVID hospital in Rome. The situation in Rome is more quiet than in other regions, but we are full, all the hospital dedicated to COVID which is our experience. Maybe I have some suggestions I want to share also with Professor Cortese. We found one reduction in the number of myocardial infarction who arrived at our center. We do usually more than 400 primary PCI per year, and there is, at the beginning, at least 50% of the reduction. Now it's increasing a little, but I think that still patients are very afraid to turn to the COVID hospital. In the other side of the medal, I think for our experience that the very high mortality in patients with COVID is due to cardiovascular complication. Maybe very late we realize that this is the real cause of the high mortality rate. Because the majority of patients are symptomatic, only a few symptoms. 20% come to the hospital are in intensive care, but all the patients with severe respiratory distress, with the need of invasive ventilation, who have a very bad prognosis, in my opinion, they have severe cardiovascular involvement. And we had 2 cases very interesting. One very young
people, 35 years old, and we did the autopsy, and he had 8-year migraine, very, very bad migraine. And another patient with severe evolution of the respiratory distress, we implanted one ECMO, and improved the situation was maybe this approach very late, too late. And this is due to many reasons. This emergency was considered at the beginning as one respiratory problem, not only respiratory problem. And as you said very, very properly in your presentation, this is one response resistant to one not said antigen, the virus. One response which loses function. So the hyperinflammation is the cause of the thrombosis, vascular thrombosis. So we now monitor the troponin and both the NSP and the D-timer just to follow the possible complication in terms of myocardial injury and thrombosis. And at the beginning, I think that should be given as preventive, primary prevention, the heparin or anticoagulant therapy patients. So many observations. I don't think that usually the drugs we are giving to these patients are so effective. Maybe the first phase, in the early phase, the hydrochloroquine and azithromycin, maybe, but I'm not sure. We do one approach of every castle, those who face very early respiratory distress. And probably we should put in ventricular assistance, not too late, patients with severe involvement of cardiac function. So many observations, we are still learning from these arrhythmias, but the problem at the beginning was to consider many mistakes. At the beginning was just to do, and then in the asymptomatic case, another big mistake that our scientific was to consider that in the asymptomatic phase, this patient was not contacted. It was wrong because I saw one paper at the middle of February from the experience of one which demonstrated that the asymptomatic phase, the patient released a large amount of virus.
वहाँ पे कोई रिकॉर्डिंग सिस्टम होता है कि यू कैन रिकॉर्ड द होल प्रोग्राम जूम में
You don't know very well what situation. So the lockdown, the use of a mask, the social distance, I think is the only very, very useful treatment for the progression of the diffusion of this disease. And in the acute phase, we have to be very careful to begin one appropriate therapy. Just the following. So the team should be multidisciplinary, and you have to do this logistic and organic. It's one organization that was not possible maybe at the beginning. In some region where, like Lombardia, which is a good national system, but maybe in all Italy, not only Lombardia, in all Italy, we have a few very little number of beds for intensive. of therapy. This was, it is difficult to readapt very quickly. One, we also did it, but it's not so easy to find the resilience of one national system, the capacity to readapt to one emergency is not so easy. Even if you increase the number, but it's not the same like you have already the real adequate number of beds. This is our experience. Maybe now and in this committee, the only specialists who are not present are cardiologists. Everybody is present. All the specialists are present.
The whole word is specialist now.
But cardiology. I don't understand why, because maybe I understand that is not correct. So it's a multidisciplinary approach which can give daily real support and can reduce the number of deaths, because all the patients who die are with very severe cardiovascular complications.
Dr. Romeo, you can hear me?
Yes.
The only question which we have from my side is why Italy was so severely affected in the beginning, because Italy was the second country affected after China. So, and why so many deaths happened actually when you are so developed. So this is something which is, people say that all the elderly people were getting infected, that was the reason. So I am not too sure. So can you reply in brief that what was the reason of such a huge mortality? Now, of course, America has gone up, but a huge mortality in Italy despite the developed medical system.
There are many reasons. One reason is not the human. The presence of very huge diffusion, very quick diffusion of one disease in one very crowded area, because the dense population in Lombardia is 4/4 that was Calabria. So it's easier to have one diffusion of one disease which is transmitted by droplets. So I think this is, and at the beginning, we have to be careful. Many scientists said that there was the people were literally the same situation of one official. So this created one delay that was the cause of not the lockdown. The lockdown should be done before, and is the best solution, the only solution.
I think people took it little lightly before, and you were the first to be affected, Italy, and people felt that it was a common cold and there was no lockdown. And India learned a lot from the European people, and we had a lockdown much earlier before this spread. What about in Tor Vergata? Are you I want to introduce again, Professor Romeo is a very senior cardiologist from Rome. His university is one of the biggest university known as Tor Vergata, just outside the Rome city. I have visited him many times, we did conferences with him. I want to know you, do you have an isolation ward, a specific ward for corona patients, or all the whole hospital is converted into COVID? What is the situation in your place?
No, we are still at the center for myocardial infarction, for stage. And so we have two lines. We have the two towers. In the one tower is completely devoted to the COVID hospital. Another tower is dedicated, in the tower where I have my CCU or cath lab. So here I have 5 cath labs, 2 in the no COVID area and 3 in COVID area. So possibility from the beginning, from triage, to send patients to COVID area or non-COVID area. But there is a problem still, because there is some suspect. So we have one intermediate area where we put the suspected. We treat them as COVID, but we put in an area as suspected with the very big distance, and we do immediately the antibody, just to know in less than 2 hours if they are a big batch of viruses or not. So it's difficult, but we, due to this organization, this logistic, we have 2 hours.
So you are happy.
Vivek, can I ask him a question?
Yeah, Dr. Rath wants to ask you one thing from Dr. PC Rath from Hyderabad. He wants to ask one question before we go to Dr. Bernardo Cortez.
Okay.
Like, Dr. Rath.
The first question is, what special relationship Italy had with China, especially Wuhan? First it hit Italy first. Second thing, to take the COVID patients who require IVP or ECMO to the cath lab or do it per side?
I think that if you have 2 different lines, separate lines, you don't have to wait. I have one campaign of my foundation of the Italian Society of Cardiology, and we know and we say that every minute counts, and it applies also now. So when we say to our colleagues to Spock Center to send immediately, because we cannot, at the beginning, until now, we are finding many patients with severe left ventricular dysfunction, with the thrombi in the ventricle, left ventricle, because they wait to come to the hospital. It's not good. So we say to come immediately when they arrive to the hospital, immediately. Each 24 hours cardiologist on site is not on duty, is on site. So for 24 hours, every patient when arriving is immediately. The time door to balloon in my hospital is there.
Okay, thank you. I think Dr. Romeo, you have to stay for the whole meeting. I will now request Dr. Bernardo to come in. But you have to stay here. You have to stay here. So, Dr. Bernardo?
Yes. Hi, Vivek.
Yes. So, yes.
Yeah, thank you.
Let me introduce you again, because for the new people who have joined, Dr. Bernardo Cortez is working in Milan for so many years. He is being expert in many new therapies like drug-coated balloons and other things. He's organizing conferences. He has done many live sessions in our conference, Indo-European course. I think you did in Vigyan Bhavan, the first course we started in January 2008. He did the live during that time. I remember when the American cardiologist, without naming him, he asked me, who is this young guy? The person who has come from USA. So I say he's a new friend of ours, Bernardo. So Bernardo, you can start with this. COVID-19 is a pandemic. What best we can do, and you can start about Italian perspective.
Yes, thank you again, Vivek, and I'm so happy to be here again with our Indian friends. Well, we learned a huge lesson from since the very beginning of this pandemic, because as you know, in Lombardy and in Milano, we were just on the trench since the beginning of this disaster. It is actually a big disaster. Since I don't want to repeat all of the useful things that all of you have said, I would like to focalize on a couple of items which are, in my opinion, quite interesting. The first one is that, like also Professor Romeo mentioned, is that the cardiovascular setting has been forgotten by many of our politicians and the healthcare system. For example, I had to lend all of my ICU beds to the non-cardiac ICU facilities just to have their patients who suffered of COVID on the most severe basis. So I had to give them all of these ICU beds, and I have to arrange all the acute myocardial infarction patients which arrive at our facility in our normal ward bed. And that was just at the beginning of this program. Later on, around 1 month ago, I had to land all of my cardiovascular team, at least 85% of my cardiovascular team, to some COVID areas. Our hospital was not a totally COVID hospital, but we had 4 different wards dedicated to COVID. And so I had to land 85% of the cardiology. So you may understand what disaster it could be for our cardiovascular patients. And I also have some data about Lombardy, which, like in all the rest of Italy, underline the fact that there was a drop of more than 50% of the myocardial infarction which arrived at the hospitals in Lombardy during this pandemic. More than 50%. So what does it mean? This means that there has been an increase in sudden death of patients which were not properly managed in the hospital, suffering from acute myocardial infarction. So these patients died at home. And the second consequence of this is that many patients will develop heart failure because they have not been revascularized by by angioplasty. So these are just some of the possible terrible consequences of COVID for our cardiovascular patients. And another important consequence of our hospital was that there have been created 2 wards, because the general director said that 2/3 of our ward would have been developed for a dedicated COVID ward. And so you may understand how happy I was this morning. I will try to share this picture with you, if you can see it. How happy I was. Can you see the picture?
Yeah, we can see the picture. Yes, yes.
Yeah. When this morning, when we were able to open these 2 walls, and so we were able also to take our beds back. So this was a great news. Because the good news is that the situation is going rapidly better and better now. Now we have only 5 beds in the ICU occupied by patients intubated due to COVID pneumonia. And this is a great news. We had 12 beds till 10 days ago. Now we have 5 beds. We have few patients with CPAP, few patients with this invasive aduvation of respiratory. So the things are getting slowly but better and better.
What about the lockdown? You still have the lockdown?
In Italy. In Italy we have the lockdown, yet we will have it until May the 4th. So it will not be, you will not be able to go around unless you are really justified by going to work in a hospital or other works which are related to the supply of general important goods like alimentary goods and so on. So this is the only thing.
Sorry to interrupt. Just to tell Mr. Anu Malik to stay here because we'll need your expert advice at the end. So if you don't have any major work to do, please stay into this and listen to our experts from Italy and other places. You are staying with us?
Can you hear me, Doctor?
Yeah, I can hear you. I can hear you.
Yeah.
Doctor, I'm so intrigued by this entire conversation, especially from Dr. Bernardo, whose voice is absolutely clear to me. And the way he's spoken about other aspects of this COVID, other than SARS, he's spoken about the heart patients, really makes me feel, my heart goes up because I've been a great fan of people of Italy. You know, and I love the food of Italy. At the wrong time to talk about pasta and cannelloni.
No, it's okay. But you stay here. You stay here. I'm sorry to interrupt, but
hear me. If the doctor can hear me, I've been to his beautiful country. I really respect the Pope, and I've been to Milan, I've been to Venice, and I've Rome, and the history of Rome intrigues me. We have seen films. If you must be very, very young, but when you must have been born, or you must have been about 10 years old. The Audrey Hepburn film, A Roman Holiday, came in. I don't know whether you know about the film Gregory Peck and Audrey Hepburn.
Yeah.
The Romans. You know it. You must have been very small. So we grew up on. I'm an artist. I compose music. I write music. And for me, we are also under a lockdown, and I'm composing music. And I've grown up on The Godfather and the Italian films, and we love everything about Italy, and my heart breaks when you talk about the deaths that happened in Italy, and we are facing the same problem in India, and our Honorable Prime Minister is fighting it out with the entire country, and Dr. Vivek has been at the helm of affairs trying to sort out everything, and it is such an honor to hear certain aspects of this disease from you, and the best part is, Dr. Bernardo, you have a smile on your face in spite of the pain. We are smiling, we are fighting, all of us. And I'm doing it through my music. What I'm doing is I'm recording songs at home. I'm under a lockdown here. And sending the songs to the public of India to motivate them to stay happy in the house. You know what I'm saying?
It's very important. It's crucial. It's crucial, really. It's crucial. What we are doing is really important.
Yeah, I'm trying to record songs and making them not panic and telling them, look, we will get through the storm. Because I'm human, when I look onto the left and the right, all I hear is news of so many thousand deaths. And panic seeps inside your body, and you don't know what's going to happen to you the next moment. But I do feel and I do believe that after the night, there has got to be a day. It's not possible that the night will go on so long.
Okay, so Dr. Bernardo, Dr. Mr. Malik, you have to stay here for another while because we will hear from you again. So coming back to Bernardo, one or two questions are there. Especially, we had a patient in Apollo Hospital in Delhi who suffered, he was 65 or 64, he suffered from COVID. He initially was positive, he was on ventilator. He became negative. We weaned him off of ventilator. He was initially on anatropes are weaned off. He had some VT, ventricular tachycardia episodes earlier. His ejection fraction was preserved. And but suddenly one fine morning when we were thinking that he might get discharged, he had a severe bad ventricular arrhythmia and ventricular fibrillation. We lost him. So this question both for you and Dr. Bernardo to answer. The patient who was almost to be discharged off inotropes, off ventilator, only very minimal pressure support, and suddenly we lose him because of the ventricular arrhythmia. Is it because of some myocarditis? And he was already on antiarrhythmic drugs. So please answer this question. It's very important. We felt so bad to lose him.
Yeah. Well, Vivek, yes, this is a good hint to the other thing that I wanted to share with you, which is a very crucial point. And it's related to the pathophysiology of this disease. Okay, this is a duplex disease, as we have seen also earlier. The first part is a viral one, and then we have the second part, which is related to the reaction of your body to this virus. And so, among of the possible complications that you may experience with this disease, there is a coagulopathy. Coagulopathy has been related to many deaths that we had in our hospitals. We had thromboembolic events in many of our patients at the beginning, and then we started giving them heparin, low molecular weight heparin, because low molecular weight heparin has two important characteristics. The first one is that it has a direct antiviral effect, and the other one is that it prevents the formation of thrombi inside of the body. And it seems to be more, I'm not talking about evidence-based medicine now because we don't have strong clinical data. We only have experience because we didn't have the time to do studies till now. But we have seen that the outcome of our patients was fairly better when we started giving them low molecular weight heparin at a dosage which is almost halfway between the preventive dosage, which is the one that you give for orthopedic knee replacement and whatever, and the anticoagulatory dosage. Okay, so that's why we started giving our patients about 1 month ago 150 units per kilogram per day in all of our COVID patients. And then another important point is that you should monitor in all of these patients fibrinogen and D-dimer. D-dimer is an important marker of coagulopathy. And if you have an increase in this marker, you should increase your regimen of low molecular weight heparin. This is an important point.
Okay, so anything Dr. Romeo would like to add on this, or we can, Dr. Romeo, would you like to add upon this what he said? All patients of COVID should be on low molecular weight heparin from the beginning, because in this patient we realized that he had inferior wall myocardial infarction because of the procoagulopathy. And we could not do the coronary angiography because of, you see, these, I have a very special, thought process that these patients, because of they are so much isolated and everybody is so fearful, they do not get exact treatment what otherwise non-COVID patient will get. So this patient could not, the cath could not be done, and we could not do, maybe still, that's why. Dr. Romeo, would you like to come in for a minute and then we go on to the other speaker? Dr. Professor Romeo, can you hear me?
Vivek, can you just ask him what is the mainstay of the treatment? Whether it's they use all patients hydroxychloroquine or antiviral? What the group must try?
Oh, Dr. PC Rath is asking, Dr. Romeo, can you hear us?
Yes, I hear you.
Can you take off the mask? I think you are in this isolated room, so it's better. Okay.
Because in my room are coming a lot of co-workers who are coming from COVID.
Oh, then you have to take care. Take care.
I think that I have to be.
So Dr. PC Rath wants to ask you something. Dr. PC Rath wants to ask you something. PC, can you go ahead?
Yes.
What is the mainstay of the treatment?
I think completely with Dr. Cortese. And I think that you have to monitor the dinner to adapt the dose of heparin to the situation. For patients who arrive in our hospital with acute coronary symptoms, we do immediately as before. Because there is no reason to wait. We treat patients as before the COVID-19. We have two different lines. So we treat the COVID and non-COVID patients with ST elevation, myocardial infarction, as before.
So there are two more questions. Dr. PC Rath wants to ask, are you giving hydroxychloroquine to healthcare workers? Are you giving hydroxychloroquine to healthcare workers as a prophylaxis?
Our pneumologists, they give hydroxychloroquine and antibiotics.
No, I'm talking about, there is a question from Mr. Kruti Janapati. There are chat going on. In India, we have Indian Council of Medical Research. The guideline, they have said that all healthcare workers should use hydroxychloroquine as a preventive method, 400 milligram once a day for 1 day, then 400 milligram once a week for 7 weeks. Is the same protocol in Italy or no? For prevention,
Yes, this protocol is in the guidelines of the Italian Society of Infectivology, but not all the centers use this protocol. Somebody thinks that at the beginning it might be useful. We use it maybe in our hospital more the tocilizumab and IL-6, interleukin 6. But there is no evidence for no one therapy, which is just support therapy and the prevention and the monitor the possible complications.
Dr. PC Rath wants to ask about the antiviral treatment.
I want to know specifically what is your regimen for a patient whether you give hydroxychloroquine with antibiotic or some antiviral drug or nothing. For supportive treatment.
Usually they give hydroxychloroquine and azithromycin. But now we think that is not so useful. After the past months,
So what?
our opinion, our impression is not so useful.
Not so useful. Dr. Bernardo, what do you say? Bernardo?
Well, we started giving antiviral treatments at the beginning with many difficulties because we didn't have the supply in Lombardy in the first days of March. And after some evidences came out 2 or 3 weeks ago, we dropped all of this treatment unless we were sure that the patient was still on the first viral part of the disease. So if there was a high replication of the virus, we gave, but just few patients, because usually the patient arrives at the hospital when the viral phase is already done. But if we are sure that the patient has fever 2 days, then we start the antiviral treatment. But the viral treatment now is used in about 5 to 8% of all of our patients.
Okay, there is a question from Iraq. There is Dr. Hekmat Izzat from Iraq. He is asking question that to Bernardo that we have seen many COVID patients presented with STEMI, but angiography was normal. I don't know about this situation, but have you seen such situation in Italy that STEMI in COVID patients because of thrombosis and angiography was normal? Question coming from Iraq. A doctor from Hekmat Izzat is likely to become fellow with us in near future in Apollo, but he is working in Iraq.
Minoca patients. Well, actually, we did not see an increase in Lombardy in Minoca patients, so patients with MI and normal coronary arteries. What, from the epidemiological point of view, we have seen instead is that we have seen many patients coming later. So after the first 12 hours, for the reason that I said before, patients fear to come to the hospital and to the first aid. So that's what we saw. I don't know, Professor Romeo, if he had other...
Our experience is that patients come very late. Because at the beginning, they wait because they hope that the chest discomfort is due to something else. But when you say you have myocardial infarction, they are very active because they were afraid to have a COVID here. Somebody said, no, I am very active because I was afraid to have COVID. But Dr. Gupta, as you know, in my hospital, I have never seen Minoca. Minoca go in other hospitals, in few hospitals. In my hospital, I see 400, the highest number of myocardial infarction, but all patients have some coronary atherosclerosis complicated blood.
Okay.
I'll have to leave.
Yeah, Dr. Mr. Malik, you want to leave now?
Yes, sir. I have an appointment at 8 o'clock.
So before that, would you like to give something which is more entertaining if you don't feel bad about it?
I'll just hum a tune on my piano that is just on my harmonium that has just come into my head.
Okay.
For my Italian doctor friends.
Okay, you go ahead, please.
Can you hear this?
Yeah, we can hear you very well.
Can you hear the note?
Yeah, we have heard, yes.
Can you hear this note?
Yes, very well, loud and clear.
the Italian Godfather tune.
Okay. But we cannot see you. We don't see you. Can you make your face a little up? Yeah.
Play it. So the Godfather tune is la ra ra di ra di ra da ra ra da ra ra di da ra ra di da ra ra di ra di ra da ra. I'm inspiring all the Italian doctors to say you come from a great country. I'll be your
One more thing, Mr. Anu Malik, for Indian people who are attached with you, just one song about that same UCI building in your voice, please.
Okay, sir. Here it goes for my Indian brothers and Indian sisters and all my people in India who I love very much. And by the way, India and Italy, both countries are very family oriented, so we love each other. So here goes. ऊंची है बिल्डिंग लिफ्ट तेरी बंद है कैसे मैं आऊं अरे दिल रजामंद है ऊंची है बिल्डिंग लिफ्ट तेरी बंद है अरे कैसे मैं आऊं दिल रजामंद है तो आजा 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 बैंड बाजा लेके आजा तेरी याद सताए दूल्हे राजा अब तो आजा. I can see the naughtiness in Dr. Vivek's face.
Thank you very much.
I love this song.
Well, I like this song.
What an honor to speak to all the doctors, Dr. Bernardo and everybody. Dr. Vivek ji, thank you for having me over. And may peace reign upon the world. May this dreaded disease go away from the world. And may happy days come back again.
Thank you very much, and we'll invite you once again next week when we'll do it. Thank you. Thank you.
Thank you.
Okay, so we continue our webinar with the continuation of the speakers. Maybe I can request Dr. Ashokan to come in, please, just to have his words from Calicut. Ashokan? Dr. Ashokan? Is he connected? Okay, Dr. Chinmay? Dr. Chinmay Gupta? I have to see everybody who's connected. Anybody wants to make a comment who's connected at the moment? Because then we'll go back to the Dr. PC Rath. Any questions? Who could ask who are connected by video? Okay, Dr. Chinmay Gupta is here. So Dr. Chinmay Gupta is a young doctor. He is my son. He is connecting here and he was there in Tor Vergata, Italy, when we were doing the conference. So what is your take about this message, one word message to the public, not for doctors, to the public?
Yeah, I have heard all the topics. Dr. Bernardo Cortes, Dr. Romeo, everyone was so great and it was so very much informative. And Anu Uncle is our favorite. Unka gana sun ke everyone is so pleased और कितना अच्छा लगता है. Thank you, Anu Uncle.
Dr. PC Rath, he's saying hello to you, my son. Yeah, Dr. Ashokan, where is Dr. Ashokan? Dr. Ashokan, is he there or not there? Okay, so I think Dr. Romeo, one or two more questions who have come in the chat. I want to ask the Italian people. Yeah, you want to come in? Madam, you want to come in? Yeah, she is the principal of Kanpur Medical College, Dr. Lal Chandani. You want to say something?
I have to leave. Sorry.
Dr. Chandani, Dr. Aarti, I can see you very well. She is the principal of Kanpur Medical College, and there was some controversy. There was something, she was very much in news. Would you like to say something on this webinar? Dr. Lal Chandani, can you hear me? I have unmuted you. I think she's not hearing well. Dr. Chandani, can you hear me? Okay, let us have Dr. Jhawar from Dehradun. What is any question you have, Dr. Jhawar? Dr. Jhawar?
If she's there, he wants to ask some questions.
Yeah, there was some question from Dr. Jhawar, who is from Dehradun.
No, this is Dr. Tripti Dev.
Oh, Dr. Tripti Dev, sorry. Dr. Tripti.
Hi, Dr. Gupta.
Your face is so similar to Dr. Aarti Ralchandani. I'm sorry for that. Yes, okay. Please go ahead with the question. She's from Hyderabad. She's also working in Apollo with Dr. P.C. Rath. I'm sorry for the mishap. Yeah. So Dr. Tripti Dev is senior cardiologist from...
Presentation of Dr. P.C. Rath and yours and Dr. Romeo and everybody. And the discussion was very nice and very, very educative and very practical. Regarding the myocarditis, because I just recently heard 2 or 3 cases from Italy only, they have presented that during myocarditis, there was ST elevation, there was very high troponin I, and the angiogram was normal, but the patient had very severe fulminant myocarditis with severe LV dysfunction, regional wall motion anomaly, and patient was put on Impella. And in spite of that, he could not make it. That was in Italy. About 3 days back, they have presented a webinar. So I just want to know exactly whether if you give any hyperimmune serum or any kind of interleukin for the cytochrome storm to reduce the inflammatory marker that is HSCRP, can it help in such patients?
Dr. Romeo, please.
I think that the many patients with very important elevation of troponin and without the severe elevation, there is myocarditis. And we are checking with every just to see if there is the acute phase of myocarditis. But one patient unfortunately died, and we did the autopsy, and he had myocarditis. So the severe reduction of oxygen can give some myocardial injury, but the increase in troponin is 3, 4 fold. You have to think about the presence of myocarditis or acute coronary syndrome. But acute coronary syndrome is easy to exclude, to control, to check, but very often they have acute myocarditis.
So,
and we put one patient on ECMO, venous arterial ECMO, cardio ECMO, and unfortunately, my opinion was great, and after we improved the cardiac output, but the peripheral situation and the pulmonary situation was so compromised that after 3 or 4 days. So I think that we had to treat these patients with normal myocarditis, but we have to think about small increase in troponin is normal, and most patients have because of the severe reduction of oxygenation, oxygen supply, but if the increase is important to check and to treat with support as normal.
Okay.
Of the first phase, that's why we use the tolechitumab. Tolechitumab is an inhibitor of IL-6. It's used very early, but when there is a storm of cytokines, I think it's too late to give the tolechitumab. Maybe you have to work before, because the IL-6 becomes from IL-1. And you can have to work very early and in pre-IL-6 phase, when there is the platform in the macrophage, and the activation of the platform from pro-IL-1 to IL-1. Maybe this is the checkpoint where we have to intervene.
Thank you, Dr. Gupta.
Thank you very much.
Mr. Motilal Sethi wants to come. He's my friend. He wants to say hello to everybody. Mr. Sethi is a businessman. He's a businessman in Delhi. Yeah.
Dr. Gupta, it's really very great initiative
of yours to have such global interactive session on COVID-19. I would like to make one small comment, and I regret also that had such a initiative was taken during the COVID-19 in China, the world would have saved many lives. So this kind of an initiative is very well thought and I think very highly appreciated. The knowledge is always there to share amongst all fellow brothers and sisters across the world. And this is a great regret that I would like to record, that such interactive sessions were not there when this COVID-19 started off.
That is true. I think there is some suspicion going on the whole of the world that in fact there was an article by the chairman of Apollo Hospital that we are facing a World War III. So it's something which we don't want to talk on the webinar, but of course we have to really come out of this soon. I would like to invite Dr. P.K. Ashokan to say a few words, because he was the person who actually told me to start this webinar. He said, why don't you have an IECR webinar? So Ashokan, please have your words.
Thank you, Dr. Gupta. Very interesting facts. Now, Italy, they are not using much of HCQ and antiviral only in specific cases, not all cases. Very important. Second one is they are doing angiogram in indicated cases like, say, acute coronary syndrome. My question is, this may be for discussion purpose. Which case they select take the patient to the cath lab, because most of the patient have high troponin and same time high D-dimer and LV dysfunction and hypotension. We don't know whether it's due to sepsis or due to the secondary to myocardial dysfunction, second to heart failure. In this situation, which patient they select for angiogram? This is my question.
Dr. Romeo, have you understood the question? Have you understood the question? Okay, Ashokan, please repeat your question.
Yes, I didn't hear very well the question.
Ashokan, please repeat your question.
My question is, in case of COVID patients, which patients you take for angiogram? Because when patients have developed hypotension, they may be in cytosine storm or secondary sepsis or myocarditis. So which patient is select for angiogram? Coronary angiogram.
I bring for the angiogram only patients with ST elevation, of course. And with experience, you can distinguish between ST elevation or myocarditis. In my very long history, rarely I did angiogram, coronary angiograms, and I found normal angiogram in ST elevation, because very often when you find coronary angiograms, it's not, because very often people with a small increase or inflammation, they say this is myocardial infarction. They do angiogram and the angiogram are normal. Usually when I do angiograms, almost 99% of patients I found coronary lesion. So in these patients, if you have, it's difficult because it's different patients. But if you find one clear ST elevation with the clinic of myocardial infarction, I do immediately this. Or I can do another step. I can do one, when I do the CT scan, I do also coronary CT scan at the same step. So I know that coronary are normal. I see the lungs and I see also, which is the important thing. So with one shot, one step. And it's possible, but when they come with they have risk factors, they have the clinic of ST elevation, and
पापा को चश्मा पहनवा के ले आओ तो एक बार मैसेज दे दें बस कि क्या करना है। पापा को अगर बोलना है तो बुला लो जल्दी से, हमें दिखा भी सकते। हाँ
मैं आपको लाइन पे ला रहा हूँ।
लाइन पे नहीं तो समझाओ तो फिर
For Spain, it depends on the clinical presentation because if one is Spain, that usually have a more severe coronary anatomy than Spain.
Okay.
But it's the beginning of the symptomatology is think of I study immediately also in Spain because I have the 24 hours hospital. Why? I co-worker having on site arrives one patient with understanding with very clinical presentation or patients with out of hospital cardiac arrest and no other possible explanation. I studied this patient before because my co-workers are there and on site 24 hours.
Okay, my question to you is because
I am very sorry, but I have to go and also.
no, only one last question. One last question is that because
I am very sorry because it's very interesting and again necessary not to honor.
no only one in our country
Indian cardiologists are my friends, you know very well.
no my question is different.
Many Indian cardiologists, the majority of my friends, the world are Indian cardiologists, we know very well.
No, my question is not cardiology. In our country, we have made a mask or any hanky on the face as mandatory on the road. Anybody who is coming out even for essential services, this I told on television on 26th March that anybody who comes out for any essential service, although there was a lockdown, should have the face covered completely so that because it was not initially thought it's airborne or not. WHO was later recommended that this could be airborne. So what is your planning? Because then I spoke on TV on 26 March and 29 March that everybody should wear the mask on the road wherever he goes out, even if he is not suffering, because he can be a potential asymptomatic carrier. My question to you is, in Italy, what is the protocol? Anybody coming out of the house has it now? The government of India has made it mandatory that anybody without mask will be requested to wear the mask on the road outside the house whenever they're coming out. What's happening in Italy?
The moment they go outside, there is the real lockdown. But in the phase already in Lombardia and Tuscany, this is mandatory to go out of house with mask. It's not possible to go without the mask. And I think that is correct because many people who are on the street, maybe are positive, are using a large amount of viruses, and you don't know. So you think it's not good for you. So we think that is mandatory, or in the basic to all people who are outside should use masks. This was the worst mistake which did the task force because they were supposed they had the wrong knowledge that asymptomatic people were not contagious. What's wrong? Asymptomatic people release a large amount of viruses. So, since you don't know the people who are talking with, they have to use masks.
My comment would be so I was commenting that is true. Since the beginning of this, India had first COVID case in 30th of January and first death on 12th of March. when I was talking about that there can be possibility of asymptomatic carrier, nobody believed it at that time. WHO said no, only when you have cough or sneezing, only then you can transmit. Now everybody says that even there are asymptomatic carrier who will have symptoms later on. Secondly, the question was whether it can be airborne or not, was not considered that time. So I was always thinking why this was, I think we are also a little late in imposing the rule that everybody should wear the mask when they're out. If this would have been done in China or somewhere, perhaps this much pandemic would not have been there. So I completely agree that we are learning. Although from the beginning I said there can be a possibility of asymptomatic carrier, and also anybody, it can be in the air for some time, for 2-3 meters for some time. Not only sneezing, people when they're talking, the virus can be there. So I completely agree with you. And I think when I made a comment on 12th March and then 17th March, people were laughing at me that no, asymptomatic carrier is not known at the time. I said we cannot wait for the guideline. We can also apply our mind as a doctor that this can happen, and we can prevent more tragedies. So there are 1 or 2 questions. Can you wait for 5 minutes because Dr. Jawhar wants to ask something. Dr. Jawhar is from Dehradun. Please go ahead. Yeah, please go ahead, Dr. Jawhar. Yes.
Vivek, thank you. I have to go. Thank you to everybody.
Yes, can you hear me?
Glad to see you.
Okay, thank you very much, doctor. I will not leave you. Okay, thank you very much. It was a great pleasure to see you. We'll continue for 10 minutes more with the questions coming up from other people. And we will talk on phone and we'll try to catch up. We'll have an ICR webinar series. Next Friday, we will try to catch up if you are available.
Okay,
bye-bye. Okay, so Dr. Jawhar wanted to ask something. Dr. Ashokan, you stay back with us. Something has gone wrong with this. Something is gone.
I wanted to first of all thank you.
Yeah.
I wanted to thank you for organizing such a wonderful seminar on COVID-19.
But I cannot see your face. Can you put your video on? Can you put your video on? I cannot see your face.
Can you hear me?
I can hear you very well, but I don't see your face. Put your video on.
Okay.
Yeah, it's better. Now I can see you. Yeah, please go ahead.
So thank you very much on this topic, making us up. I was in the Guardian Institute. I am not a medicologist. Wanted to know that it was a discussion. There are so much of advanced. We can do heart surgery, bypass surgery, and all that. But in all these years, we have neglected the communicable diseases like this. So the future research, what you think should be in the communicable diseases also, more attention should be paid.
Sorry, I could not understand your question. Can you repeat your question? Ashokan, have you understood the question? Can you answer his question? Ashokan, have you understood his question?
Communicable diseases, this type of communicable diseases were not paid much attention.
Yeah.
We can do dialysis, bypass surgery, open heart surgery, but not much attention was paid to this kind of disease, like when it goes from one person to one person. Communicable diseases, I think it is called communicable diseases.
I think it's very valid point you raised. I think in future we can expect at least 1 or 2 episodes, maybe 1 or 2 years. I think that's a prediction. So we don't know, just like a viral infection, we don't have a right treatment present. I think it's going to give more importance to such communicable disease. I think it's very important.
I think
there's a difference in mortality in India versus other countries. India is 3.5%, but Europe is around 12 to 15%. USA, the mortality is still 3.5% only. We don't know what is the reason. So many things we don't know. And we don't know the test, when we have to do, how to do, and how often we have to do the test. A lot of things we learn. And we don't know the specific treatment for this. Here there is a very valid question. So I think it's very lot of importance to communicate with disease like this.
Okay. Any other thing which Ashokan would like to highlight, because then we have to wind up. Maybe anybody else who wants to come in?
There is a change in pattern of the COVID. Initially it started with the elderly, so that is very fast. This is more elderly people. now we see a lot of young people affected. And still we don't know the fatality rates remain the same in young persons. So we have now learned about the lockdown and quarantine, and we are stressing more of reverse quarantine and keeping the elderly away from these infected persons. So I think keeping the infected persons in one side. I think the concept is very good in India. I think lockdown and taking care of the elderly people and giving prophylaxis to the high-risk group. I think this concept is good.
Yes, yesterday Prime Minister...
very low, and even though some places around 6%, other places in Kerala like say less than 0.5%, 0.2%.
What about the testing? In Kerala, I think you have the highest number of testing done. Is it like this? I was reading in the newspaper.
Testing is not done because the availability of the kits. But what we have done is we strictly implemented the lockdown, started the preventive measures in the early, quarantined the travelers because international travelers only initial persons. Okay, then the other people. So I think it's now we isolated those group and given the treatment in the early phase. And those two patients died, both have got comorbid, let's say, other cardiovascular and renal failures and other things. So otherwise, the outcome is good, and there's fast recovery and low infectivity. These are the things we have learned. So I think the most important thing is the social distancing and other precautions.
Yeah, Dr. Tripti Dev, what about in Apollo, Hyderabad? What's going on? Because how many beds do you have preserved for Dr. P.C. Rath can also join for this? How many beds are there in Apollo, Hyderabad?
A separate wing away from the hospital. There's a COVID block, where there are around 30 beds are there. Where the ICU is all managed by the infectious disease people. And we had two patients who succumbed to this COVID-19. And this is two patients who came from Nizamuddin. And they didn't have any cardiac problem, pre-existing cardiac problem, but they had severe pneumonia and they had hypoxic and they put on ventilator, and both of them were lost. And two patients, COVID-positive patients, were admitted, but they recovered.
So, when the cardiologist goes...
They are all COVID patients. We are sending to Gandhi Hospital, Chest Hospital and Fever Hospital.
I just wanted to know from you again, yeah, Dr. Tripti Dev, please go ahead.
There is a possibility of getting the vaccine after 1 year only. So do you recommend a BCG vaccination? BCG vaccination? Hello?
Yeah, I'm hearing you. Please go ahead.
Hello? BCG vaccination would give some prevention, to prevent the severity of the disease in such cases.
This is a very valid question because in fact I asked my wife the other day that we all had BCG or not. First of all, I'm not fully convinced that BCG actually is a thing which can give immunity to the virus. My view, and there is no such discussion as such, but there is no harm because I don't know who raised this point that we are vaccinated by BCG and therefore we are a little more immune to this virus disease. Any link, Dr. P.C. Rath, do you have? Or Dr. Ashokan can give highlight because I'm not sure from where this came, because BCG is for tuberculosis. It's a bacterial disease and we all are vaccinated, all of the Indians, most of them, 99%. Whether that is the reason why we did not have so many deaths, I'm not too sure. So Dr. Rath or Dr. Ashokan can have some highlight because I cannot answer this question. I'm not fully convinced myself that BCG is actually the cause of less mortality in India.
The geographic distribution of the African people, there's a difference. There's a difference in south also. There's a difference in each state. There's a difference in Assam versus Kerala versus Delhi or Bombay. So all these people are vaccinated with BCG. And why some people are affected more, some people are affected less, we don't have an answer. Whether there's a total virus load or any other method for the transmission in this group, that's important. Second thing is in India, most of the people affected with COVID. I'm not talking about the persons who have died or young people. Affected. Then those who died, most of them are above the age of 60 years. In those cases, 60-40. That's a ratio. I think these are the important things. Still, we don't have an answer for this. I think we will see the research, some studies.
Okay. So I don't think there is any recommendation for BCG for such. I don't think so because Doctor.
One of the reports I saw in Northeast, the incidence is very low, COVID incidence. And one of the postulations in Northeast is very. Malaria was random. Almost epidemic purpose. A lot of people had chloroquine and all that. Probably that is the reason why they are resistant something they are not getting it. It's really in all Northeast they know this COVID.
I just want to know, we are all doctors. Have you all taken chloroquine or not? Hydroxychloroquine or not? I have taken myself as recommendation of Indian Council of Medical Research. Dr. P.C. Rath, have you taken hydroxychloroquine?
I might have taken, but I am taking as a prophylaxis now. Because I see a lot of, I come from many primary angioplasty. I don't know whether many of them are not tested. I do not know whether they are infected or not. As a prophylaxis, I am taking.
That's very important. That's what I am telling.
IMC are not stressed on the.
Once in a week, that is on Sunday, I take 200 mg 2 times a day. Every Sunday.
That's very.
As a prophylaxis for malaria, that same dose I take for this also. 200 mg twice a day on Sunday.
But hydroxychloroquine, not the chloroquine. Hydroxychloroquine, yes.
Yes.
Of course.
Hydroxychloroquine.
Anybody else who is there still online would like to comment? Dr. Kansal would like to come? Would you like to say something?
Yeah. What about smallpox vaccination?
Sorry, what is your question? What do you say?
Smallpox. What about smallpox vaccination?
Dr. P.C. Rath, your colleague is asking to you, smallpox vaccination.
All these postulations are very difficult to answer, but the fact that our numbers are increasing, now you see the numbers are increasing and we are not doing enough testing. So we have time will tell whether really where immunity is more or not, time will tell. So number is gradually going up. We are not testing adequate number of patients. Now the testing facilities increased. End of April we'll see. Because time only, because I have a strong feeling that it's going to go very high, these numbers. Because we are testing very, very less number of patients.
I completely agree with you, and I will say that I think that the lockdown have to be further increased because this again this is not going to slow down so easily because as you told us that numbers are going to increase with the increasing testing facility. Dr. Kansal from Meerut would like to say something. He is our old colleague and friend. Dr. Kansal is working as a senior physician in Meerut. Yes, please.
I have been advising my patients, my friends, doctors. Just to when they examine respiratory patients, they should keep their offices open or they examine them in open on verandas. Patients of sneezing and coughing must be examined in open, not in offices having distance. Do you agree or not?
Yes, very good point. Excellent point. Excellent point.
Okay, that means the offices should be open to air. But we in Apollo hospital, hospitals like yours and ours, it's not possible to do it.
No, I keep my door open.
Yeah, the carpets you can do it.
Yeah, I keep my door open.
Moreover, yeah. And do you suggest steam inhalation for doctors who examine the patient after this respiratory patients? Will steam inhalation do something good?
Maybe.
I think it's a good point because you see somebody has told that we are still learning that this virus, if you take hot water, I am not too sure whether it is going to work. It's all postulations. So the same thing you say, steam inhalation after you is to help us psychologically, and washing your clothes when you reach home. So all these things are postulations. I think the best is to keep your hand hygiene best. And
it doesn't cost much. Steam inhalation, drinking hot water doesn't cost. Maybe it may work. I don't know. Nobody can tell us your case and no. So if you believe it is going to take out your virus, please do it.
Mr. Om Prakash, would you like to say something? I'm unmuting you.
There are a lot of social media, a lot of is coming out. You know, these boosting inhalation 4 or 5 times, drink hot water, all this, a lot of non-pharmacological treatment. Anyway, there is no treatment for it. There is no treatment for this virus. All this chloroquine, antiviral, nothing is true. You have the Italian doctor, all supportive treatment. So, any non-conventional treatment is worth trying.
Yeah, Mr. Om Prakash, would you like to speak something?
Thank you, Dr. Gupta ji, for a wonderful interaction between the doctors about the COVID-19. Basically, I am from Dehradun, and here in Uttarakhand, only 33 cases are reported, and out of which 9 have been recovered and no death. So, due to the lockdown here, everything is under control. Thank you.
Uttarakhand is, I think, blessed because of the lockdown. So I think we have to really give a credit to the government and the Prime Minister that putting a lockdown on 22nd of March was a great, in fact, movement, and we have learned from Europe. The lockdown in USA came very late, in Italy came very late, because they all felt that it's a common flu. So I think that's why the lockdown has to continue, and I feel that it will continue even after 3rd of May. Although this is going to happen, to give a big jolt to the economy and the poor people who are not able to feed themselves because of this. Any other question, or we can end this webinar? There is Drishti Pachauri. Are you available? Because she had a question. Dr. Raj, can you answer? There is a question from Drishti Pachauri on the chat. How much time coronavirus takes to replicate itself after treating fully, and in some cases symptoms also not appear? Then what we recognize that? I mean, it's not a very clear question. How much time the virus takes to replicate? Virus is replicating all the time, actually. Virus is replicating all the time, and once you are, I think she's asking the second wave. It's a very important question to answer, Dr. P.C. Rath, because in China, those patients who have tested negative and they have tested positive again. So people are talking about second wave of coronavirus, COVID-19, coming in Italy now as COVID-20. What is your thought process?
You know, there is a group of the philosophy. People are thinking probably like, this virus gets irradiated with after some time, then it stays with the patients after some time, and the immunity, there's always a fight between virus and immunity of the body. And when the immunity comes down again, the virus becomes active and you get first degree. That's what is happening in North Korea, that's what is happening in China. So they feel that after some time, virus load comes down drastically, but still it remains. Test becomes negative. And some of the people, the immunity starts coming down later, and again the virus takes up again. So that is what the virus never dies down. That's what people think. You are a constant carrier.
You are a constant carrier for how many days? For how many weeks?
Nobody knows. This is a new disease. Everybody is learning. Nobody knows. That's what everybody thought. The virus, COVID test is negative twice. He's free again. They're coming back.
So I think the best is to improve the immunity. That's the best thing to do it. And I'm advising all my patients, not only patients, the public, to start using vitamin C and CoQ enzyme. I don't know how the CoQ enzyme will help, but these are the salt and products which are known for increasing the immunity. There's a question that...
Yes, definite vitamin drug has been being used for many years for preventing increasing the immunity.
And vitamin D also.
In fact, I'm taking vitamin C now every day.
You see, there is a study I want to share here. The study which has shown that to have vitamin C to increase immunity, it should be at least 10 gram per day. So it is not possible to take 10 gram because there is a study of I have seen in the reports. So 400 milligram tablet, 2 tablets thrice a day at least should be the ideal to take it, not to have just once a day or one tablet a day. There's another question, last question I think we'll take up and then we'll wind up. There's a question from, I don't know the name. Can we use SCQ with azithromycin in cardiac patient? SCQ with azithromycin in cardiac patient. There's a question from somebody, the name is not there in the chat.
Anyway, I recommend, because first thing is now its usefulness is being questioned. Second thing, cardiac patients, they already are the high risk of developing prolonged QTC and arrhythmia. So why to take the risk? I suggest.
Because you cannot monitor the ECG every day, and it's impossible to monitor unless the patient is hospitalized and you are seeing the QT interval all the time. I think the last word coming from Ashokan, and then we will wind up. How many people are there with us? There are a lot of people still. Anybody wants to comment here? Anybody? I think a lot of people have not put the video on. So I think let us, any last comment from anybody would like to say? Dr. Johar, you want to say something?
Very interesting. This one. Yeah, please.
Our standing ovation to all the doctors of the country.
Thank you very much. Thank you very much. Dr. Ashokan, the last word.
Yeah, very interesting point there is whether the infection can come back. So now once a patient is PCR negative, how to follow up the patient? Whether to do immunological test, apart from the molecular test in these cases. I think it's very important. You need to follow up the patient with the immunological test. When to do and how to do, that's a question. And whether we can do it outpatient because of the cost.
Okay, I think you're right that we have to keep follow up the patient and do the we cannot once the PCR is negative, then there is no need to do the testing of the PCR again. Is it we should do after 1 month or 2 months?
That we don't know.
We don't know.
Do the test, repeat the test.
Dr. Naseeb Lal would like to say something.
Some cases the PCR is false positive also and false negative. These are the two issues we are facing now. Because the quality is
with this
or a lot of things like that.
Patients have come back to this testing.
Sorry, what you say, Dr. Rath?
Now that again patients, recovered patients are coming back again and they are showing positive, COVID-19 positive. So only when they become symptomatic, at the time you have to do the COVID test.
Okay.
So the patient recovers, when the patient becomes again symptomatic, then only you can't go on doing it. So that's the only recommendation.
I think that somebody from Mr. Badri Narayan wants to speak something.
Yeah, he's from Hyderabad.
Okay.
Yeah, before administering HCQS, you want any preliminary ECG to be done or the electrolytes to be mandatory to know the prolonged QT. You see some Assam doctor expired due to prolonged QT taking after HCQS.
Yeah, you should, because if it is in all these patients, cause of getting chloroquine, QT prolongation and hypokalemia, you have to exclude these two things. So I really do ECG and serum potassium because we are putting
electrolytes, right?
Yeah.
I think
so. And at the same time, in specification,
we should take the baseline ECG. And before you take next dose, 2 hours after the second dose, if possible, you can repeat the ECG. Or you should have QT monitoring by any method, either the telemetry or any other methods. But it's easy to monitor, as Dr. said, the hospitalized patients easy to monitor. We can check the electrolytes and other parameters, potassium and magnesium. These are the things you should take. And any other medicines, suppose they take any QT prolonging medicines, I think should be careful, like azithromycin or any macrolide antibiotics.
And some patients, I think some patients had hypertrophic cardiomyopathy, the one who expired.
Yes.
That's and many patients who have expired, they have taken a high dose of chloroquine.
Okay, there is a Dr. Mr. James Bullas from Nigeria. I think he was raising his hand. Is he still there? Then I'll ask him to talk to you. Mr. James? I think he's gone. Mr. James, how are you?
Fine, I'm doing fine, Dr. Gupta.
Good to see you. Good to see you.
How are you?
How is Nigeria? How is Nigeria?
Yeah, Nigeria is doing fine. Nigeria is doing fine. Thank God we have, our government is trying to contain the virus. The country is doing fine, and we pray that God will take control.
So you still have that? You also have the lockdown?
Yeah, we are on lockdown. Major cities are on lockdown.
And what about the villages, small cities?
Yeah, small cities also, but some are being relaxed because of no report of virus.
Okay. So that means you are lucky to be not having too many patients. How many patients are there?
Well, we don't know. We don't know. We don't know yet.
Okay. Take care of yourself and your family, and we hope to see you soon. And take care. So, anybody else would like to speak? Anything? Madam Tripti would like to have last comment, and then it's already 2 hours we have been here, and it's a very successful webinar initiated by Dr. Ashokan, and then of course Dr. Rath, supported by Dr. PC Rath, yourself, and 2 Italian cardiologists. We hope to have a webinar again next week on Friday. So let's see how many. I'll try to correct some American and French people. Dr. Alain Cribier was not available, otherwise he could have joined. But I think we will see some American people, because America is suffering much more than Europe now. Dr. Tripti Dev, would you like to say something?
Yes, I would like to say that we should be proactively preventive and start the proactive prevention very early, not too late. As soon as the earliest symptom of anosmia and the ageusia and the lack of taste and lack of smell starts before any rhinorrhea, we should be very proactive to understand that that person is having viral replication in the nose, nasal mucosa, as well as in the throat. So that time only if hot water can be given all the time, so that the virus goes directly into the stomach, not into the respiratory tract. If that can be prevented at that point of very early indication of viral replication in the nasal mucosa and the nasopharynx, I think we have won the case, and we could prevent and stop the replication of virus going into the lungs, and we can win that case as a very early curative phase. So that much is I should tell you.
I think it's a very valid point regarding anosmia. I have not, because you see, when we have patients of corona here in our Apollo hospital, I have not visited them. One of the patients was there, then I had to telephonically, because we are all scared. There is no point. So we have a respiratory team going on. So I think almost all of them will have anosmia, or it will be only few percentage will have anosmia. The lack of smell and taste.
Actually, when I was going through the webinar with the Wuhan and entire world, initially they have told that though there may be about 50% to 40% patients may get, but they have to be careful and they have to be understanding their symptoms. So that means we should have a complete awareness towards our smell and the taste, so that we can understand the virus is replicating, started to replicate. So that is a very important point. And one more important point, that we should count 1 to 30 within 30 seconds. If we are not able to count, that means the respiratory capacity is going down. So that we can always check. So check. Every person should morning and evening check on their own respiratory smell, taste, ageusia, and the capacity to count up to 30. If that is possibly done every day, we can prevent very early replication at the early precaution.
But madam, my point is that this is you see, when you said that able to count till 30, that will happen only once you have a disease, and which should be good enough to go into the lungs, and you should have fever before that. Fever and cough will come before this symptom. Do you think that this symptom can happen before the fever and cough?
Possibly because we are seeing some patients without much of cough or fever, but still they have respiratory symptoms. So we don't know exactly at what point which patient will present in which kind of condition. In seriously, I can't say exactly what is the exact presentation. I think it is very individual kind of response. So, but we have to be proactively attentive. So every person we should educate the entire public. We should educate everybody that to take care of their own, to introspect their own way of looking at their personal, means not only hygiene and not only all the proactive prevention, but these aspects also, so that we can prevent the disease going down into the lungs.
Okay, I think that's a valid point. But it's very scary then that patient can have a lung problem without fever and cough, because then the patient will not be able to know, or in fact doctors will not be able to come to know that this patient can be this is something more dangerous than, because without having something like asymptomatic pneumonia or directly pneumonia, and then you'll end up in a severe problem. That means everybody has to count till 30 and we have to do it every day, at least once a day. Mr. Rajiv Prasad is our old friend from Ranchi. I think I have just, hello, how are you, and would you like to say something? And he has actually...
I am doing fine, doctor, under your supervision. I have a question to ask the panel. That I am a patient of PTC and I've got 2 stents implanted by Dr. Vivek. I was wondering if these SPQ pills 200 milligrams, is it advisable for us also to take it, because we are under severe medication of, Brilinta and aspirin and all that, and many other and cycling drugs.
I think Dr. Rath, please answer. He's my patient, old patient. We have done 2 stents in RTA. He's in Ranchi. It's a very valid point, because you see, as of now, hydroxychloroquine is indicated. No, he said hydroxychloroquine at the moment is indicated only as a prevention to healthcare workers. And he's not a healthcare worker. He's a cardiac patient. And he's a quarantine. He's almost staying at home. So would you recommend him to take hydroxychloroquine if his ECG is normal?
He doesn't take it. So first he's not exposed, and secondly he has this cardiac problem. He's taking all these medicines, and this will do more harm than good. So benefit this anyway. You do not need any prophylaxis.
I think you should continue. You add on CoQ enzyme and you add vitamin C to your prescription. Vitamin C and vitamin D also, because vitamin D is also known. Even with the normal vitamin D levels, vitamin D taken in a guarded dosage also helps to increase the immunity. The CoQ enzyme, vitamin D and vitamin C start all these things other than your medicine, but chloroquine, hydroxychloroquine is not indicated as a prophylaxis as of now for the patients who are not exposed, only for healthcare workers. Any other point from anybody else? Anybody else is waiting for his turn, because now we have to wind up the whole thing, and it is a very great webinar. Dr. Chinmay, are you online? Dr. Chinmay? Dr. Ashwini Gupta? Okay, so I think it's a very great, day. Dr. Rath supported us a lot, and Dr. Ashokan initiated the whole process. And I want to take opinion from you. I think what next week we will do with the help of American cardiologists. I will take 2-3 people